So we'd like to switch to our next speaker. Our next speaker is Dr. Kent Allen. Dr. Allen is joining us today remotely from Virginia, I presume, or he might be in Florida or he might be in another country for all I know. He travels quite a bit. Dr. Allen is a graduate from the University of Missouri. He started his practice in Arizona, and after spending some time being the head vet for the Olympics in 1996, he moved his practice and created a new entity with Virginia Equine Imaging. And that entity was the first in the country to establish equine imaging as a specialty. And he's carried that on for many decades now. And he works very closely with a lot of our equine professional athletes in different parts of the country. Dr. Allen and I work closely together as he is the chairman of the USEF Veterinary Committee as well as the USEF Drug and Medication Committees, and he works closely with the FEI. We're very fortunate to have Dr. Allen today, and he's going to be talking to us about lameness in equine athlete, problems with the hock and proximal suspensory ligament. Dr. Allen, appreciate you coming and joining us today, and thank you very much.
Oh, thank you. Appreciate being here. It's kind of a cold, snowy day in Virginia here, so other than going out and getting on my bobcat and working in the woods, I didn't have a whole lot else to do, so I'm glad to join you guys. What we want to talk about today is hind limb lameness in the athletic horse, and because that's a fairly wide area, we are going to focus in on the hock and the proximal suspensory ligament. Like I said, I'm at Virginia Equine Imaging, and we're a 6-practitioner practice. It's a purpose-built facility for lameness and sports medicine. And we do not do surgery. We focus only on diagnostics and then medical treatments, refer the surgery. My personal aspect of the practice is that I just do second opinions in clinic, have numerous other excellent veterinarians, Dr. Rosillo, who's been team vet for US dressage, Dr. Johns, who is currently and has been for some time team vet for US eventing, and Dr. Abigail Atkins, who is in the midst of finishing up her medicine residency and has worked at our group. So it's a great group. We see a lot of different problems in the hind limb in athletic horses. Our primary demographic is going to be primarily the English sport horse, but we do see some Western horses. And certainly we see race, steeplechasing is large in our area, and eventing. This is kind of the heart of eventing in the United States and where the majority of the upper level event horses come from. And then they travel around during the year. So let's talk about what, in the hock area, what problems do we see? And obviously hock arthritis is the most common, but what some practitioners are not aware of is a lot of the arthritic conditions we're going to see have started at a fairly young age as developmental orthopedic disease. And that's OCDs such as the distal intermediate ridge of the tibia lesion, which is quite common, central tarsal bone crushing, which then you see the sharpening and arthritis on both the tarsometatarsal and the distal intertarsal, which is the most common area that we see arthritic changes. And a lot of that comes from that developmental time frame when the horse was growing rapidly. And then the proximal dorsal MT3 enthesiophyte on the tarsometatarsal joint. And that will present as a large spur. And I remember as a young veterinarian, I've had the opportunity to do this profession for a long time, and I had numerous fantastic mentors along the way. One of them was my father, who is a very prominent veterinarian back in Missouri. And first time I saw one of these large spurs in a 2-year-old, I asked my dad, well, how did he get that from working that hard? You know, he's only 2. And Dad pointed out, he said, that's a dysfunction between this horse had a growth spurt at a young age as he was developing. And what happened is that the bones grew quicker than the ligaments did, and they pulled that bone up, and that's what gave him the spur. Now, it's great to know that because you can answer your client's questions in regards to that. It doesn't change much in the clinical picture because as time goes on, that bony abnormality will certainly cause arthrosis in the future. And so you're still going to have to deal with it and treat it. But it is important to know that a lot of these problems, and this is true, of course, for other joints, you know, the OCD and the medial condyle of the femur, the plantar fragments off the plantar eminence of proximal P1. All those are developmental orthopedic disease, and a lot of the problems that we as veterinarians are treating have come from this developmental time frame, and we have to recognize that. And if you can, I don't have any involvement in the breeding industry or with breeders, but you know, you talk to them about avoiding growth spurts because that's where a lot of the problems are going to come from. So when we're looking at a set of hocks, again, you know, it's important to recognize what the hock is doing, and those 2 bones, and primarily that's the central tarsal bone and the third tarsal bone, they're functioning primarily as shock absorbers. And so that's where, as time goes on, you're going to see that problem. And then, of course, the upper joint, the tarsocrural joint, is a complex ball and socket joint with a variety of complex ligaments that are doing different things, both medially and laterally. And so for this to work, you know, we've got to do what we can do to keep the shoeing correct, monitor how this horse is doing. Do they all need injected? No, clearly not. Should injections ever be done on a routine schedule? No, you should examine the horse and determine if it needs intra-articular injections, and we'll talk more about that. So remember what's happening back there in the hind end. Like I said, the hocks are the shock absorbers, absorbing these concussive forces as the hind limbs strike the ground and propel the horse forward. The front limbs are doing the balancing act with 60% of the weight up there. But that biomechanical push is coming from the hind. And then we talked about what developmental orthopedic disease does and requires this treatment when the horse is still quite young occasionally. Again, driving propulsive of the hind limb puts a lot of stress additionally in the proximal suspensory lesion. And one of my mentors, Jean-Marie Benoit, has talked to that, did the Milne lecture at AEP this year and focused on what we need to be paying attention on biomechanical changes and stressors that sometimes we don't pay enough attention. You're going to, in the horses that engage in these athletic professions, eventing, dressage, show jumping, reining, they are going to be at risk for both hock arthritis and developmental orthopedic disease in their hocks, as well as proximal suspensory ligament desmitis. And footing has a role and a component here because we see deeper surfaces in arenas commonly, and we see, it used to be dirt, sand combinations. Now, you've got every kind of synthetic footing, some which grab the foot and don't let it slide much, and others do excessively let it slide, but sometimes are quite deep. And all those have different strains. And can footing be implicated in seeing some of these problems? And clearly it can. Just here in Virginia, we've seen footing that was artificial footing been brought in, and immediately started seeing proximal suspensory ligament desmitis in that group of horses that they had never had before. So you do have to pay attention to what those footing surfaces are that the horses are training on. So as we look at predisposing factors, particularly on the proximal suspensory, and we're going to talk about this area here, which is the origin of the proximal suspensory. And again, we need to be aware of the biomechanics of it, which is that we see these two muscular arms or crura that are attaching here. And as we see that, then the question is, well, one side is going to take up more stressor than another. And because of the biomechanical action of the horse, that is going to be in the hind limb, that's going to be the lateral aspect here. And that's where you're going to see a lot of the changes, as well as this area here where the attachment is. But remember, it's also going up where you're not going to easily see it, either on radiograph or ultrasound, up into that lateral aspect underneath the splint bone. And in the hind limb, the anatomy is slightly different. We're going to have some different looks at this, but that's important to realize because there are numerous things we want to appreciate as we're doing this deep dive into proximal suspensory ligament desmitis is, well, why is it bilateral in the hind limb where it's unilateral in the front limb? It's the same anatomy, right? Well, not really. As we look at this, the splint bones are much larger, okay, in the hind limb than they are the front. And then that sheath that I'm going to show you in a minute here on ultrasound, that sheath that wraps around the proximal suspensory ligament is much denser and longer in the hind limb than it is the front limb. So even though, yes, the anatomy is the same, there are enough changes there to make a biomechanical difference. So with hind limb, again, we're going to summarize this and come back to it several times, but it's a great biomechanical design with that sheath wrapping around and that deep canyon that the proximal suspensory ligament resides in. And it's designed to reduce the vibration of the ligament. But because of that design, which it does very well to reduce the vibration of the ligament as it drives the limb forward, it becomes a liability when the ligament is injured and swell, because what happens then is you get compartment syndrome, vascular restriction, nerve damage, and then you can actually get degenerative changes to occur within the ligament chronically because the ligament is not getting a normal blood supply. And of course, without normal blood supply, we're not going to heal. And that's why these horses if you look at the literature and the data, shows in one study, 11% of horses got better with rest. In another study, 20% of the horses got better with rest. So the answer is they're not going to get better with rest. If you want to go put them in a pasture for 6 months, the likelihood is you're going to pull them out of that pasture and they're going to look exactly the same as they did before. And again, remember that because it's the hind limb and that difference in anatomy is you're likely going to see it bilateral. And so it's common that you take the lame leg and block it, and then that horse improves on that leg and switches to the opposing hind limb. And that's quite common. So again, all of these problems, you know, the compartment syndrome, this confinement within the plantar fascia and splint bones and the back of the cannon bone, and the vascular flow reduced. And we have seen now multiple papers that show that deep branch of the lateral plantar nerve is damaged commonly. And it can cause neuropathy, prolonged lameness. You can get bony issues. There are a variety of ways you can have proximal suspensory ligament desmitis. So again, just to make the point here that this structure is very deep within the limb. So it's all covered up by the superficial, the deep digital flexor tendons, and then the accessory ligament, and then you're finally getting down. So people go, well, gee, I palpated that, but I didn't get much. Well, that's not surprising. You're not commonly going to get much on physical palpation. That structure is too deep for you to be able to assess adequately. So you're going to have to assess it other ways. So as we look at both the anatomy and the ultrasound anatomy, and then we appreciate the fact that there's a variety of unique things about the proximal suspensory ligament. And one of them, again, as we've talked about, is the sheath across the top, this large canyon that the proximal suspensory ligament resides in, and then just the ligament itself. Again, one of its terms is the interosseous ligament. And if you look at it, why it's unique is there's collagen, muscle fibers, and fat in this area. And some of the ways that you are assessing that with, say, an ultrasound is here are these same areas seen on ultrasound, and they can be pushed away due to an injury or a swelling at that attachment for the proximal suspensory. And so here's a medial view, and you can see again, curve of the splint bone, curve of the splint bone. And then here's the plantar view. And the plantar view is challenging because you're not going to see all the structure all of the time, but you're going to see, and it is very important when you're doing this imaging that you be able to see this cannon bone right here. Okay, that is critical because that tells you the limit. If you can't see the cannon bone, then you don't really know where you are. And so here, one of the things that we look at as we're talking about what we're seeing in this proximal suspensory is people like to measure this, and you can sit here and spend hours on cross-sectional areas at different levels. But Dr. Selberg and myself have talked numerous times about what works better is to simply measure from the inside of that splint to the other inside of the splint And the question is, does the swelling extend outside of that? If it does, then you have a damaged ligament without doing cross-sectional areas. And so that tends to be a very useful way to do it. And it's seen best on that medial view. All right, so we've talked about the predisposing factors, anatomy. You can see these same things with MRI. And you can see also that here is a picture of the attachment right here with proximal suspensory, the same area that we're seeing here on the anatomy specimen. Okay, now a little further down on this next MRI sequence is we're seeing a gap here, and that is normal. You will see the proximal suspensory in a normal horse lift off of that area and have that gap. If that gap is not present, again, you have swelling and a problem. So, summarize the etiology. We're going to see acute strain. We're going to see fatigue. That's commonly how this happens. It can be either way. The swelling becomes a compartment syndrome. Blood flow is reduced, and the ligament is unable to heal normally. The horse does not improve with rest. So that's our etiology of the injured proximal Spencery. So we're going to look real quickly at what is correct hind limb conformation as we're looking at, because we talk about this all the time. You know, hind limb conformation, you know, can this be a part of this? Well, yes, it can be. And this horse has quite normal conformation, a little upright, but this is completely normal. And this is a horse who's a first field fox hunter and done this job for a lot of years, and never had any problems. So then you look at some other horses that are getting straighter. Okay, and this chestnut on the left is looking quite straight through the hock and the stifle, but still, you know, within margin of normal limits. Now the gray is not, okay, and you can look at that and you can see how flat this stifle angle has become and this hock angle. And that is going to push more weight down on to that fetlock and push the fetlock down, which is going to increase the strain on the suspensory apparatus. Okay, as time goes on with that, what will happen is you will get fetlock joint hypertension and hyperextension, sorry. And that's what you're seeing here. It's present, but more subtle in this gray, and it is definitely present here in the dark horse. So one of the important things to talk about is shoeing strategies. And we want to have a neutral, balanced foot, okay, with the breakover, again, toward the center of the foot. Ideally, we want a shoe with increased width in the toe and narrow in the heel, and keep it on 6 to 12 months or longer. Some of these horses wear these shoes for the rest of their career. You can use a shoe with biomechanical heel support, but only when the proximal suspensory is so compromised that switching the strain to the DDFT, which is what the shoe we're describing above does, is so compromised that you're going to switch the strain to the DDFT. And these horses are not usually athletic. They have progressed far enough in the disease that they're probably not coming back. And so it's important you look at each case and see where it is in the course of the problem and whether or not it can use this proximal suspensory shoe. And I'll show you a picture of it a little bit later. So what's the history? Okay, and this is true for hock or proximal Spencery desmitis. Can be acute, mild, moderate, severe. It can be chronic, and commonly the hind limb is chronic shifting leg lameness. Decreased performance sometimes is the history you'll get, and occasionally it will progress to the point where it is involving the branches as well, and usually that's the medial branch first affected. And commonly there's a history of hocks injected in the PSL. And then you see varying degrees of severity of the lameness. Flexions classically are strong, and as we've talked about, can be bilateral and can be thickened bilaterally. So how do you diagnose it? Well, you determine if the hind foot, the fetlock, or the mid-metatarsus is involved. And, commonly we want to get that out of the way. We're going to do a distal metatarsal block or a low 4. We're going to block that, get the fetlock out of the way. If it blocks, we're going to go back and reinvestigate that foot fetlock area. You should have already ruled out branches in your physical exam, but you can always ultrasound those if you block and you have a question. If you're wanting, the simplest way to get to the hock is IA blocking, and that is still the gold standard and the most definitive way to do it. Proximal Spencery blocks deep branch of the lateral plantar nerve or direct infiltration of the proximal suspensory ligament origin, or a tibial nerve block. Any of the three will get it, and I have horses that I've had to do all three. So it is important you know how to do these various blocks, and if you're going to do direct infiltration, you're going to need to do your ultrasound ahead of time, because you're going to introduce enough artifact you're going to have trouble visualizing that. Okay, so if you're going to have a diagnosis of the proximal Spencery ligament, you're going to require a positive response to the block and corresponding imaging changes. The most common of the imaging changes is going to be ultrasound. You should do at least a DP view and a lateral view of the hock area, just to make sure you're not going to be surprised. And then scintigraphy is quite useful, as is MRI, particularly in the cases that if we're looking at on the ultrasound and radiographs and we're not finding the answer, that answer may come to you from scintigraphy or MRI, because it may be bony infiltration that's not going to show on ultrasound. And as we talked about, this medial oblique view is very common now up here. And here we're talking again about taking it from one splint down to the other, and you can see the curve of this abnormal proximal suspensory rising up out of that well formed by the splint bones on this that's transverse view. And remember, the norm nowadays is to do both a weight-bearing and a non-weight-bearing views, and there's sometimes a non-weight-bearing view will be significantly different than the weight-bearing view. On this sagittal view down at the bottom, one of the things to look at is this irregular bony surface here that we're seeing at the proximal attachment. And that is, again, indicative of the ligament pulling. We also talked a little bit about this space down through here that should be there. It's not present here. And that is, again, another sign that there is swelling present in the suspensory ligament. Okay, as you're imaging, again, you want to rule out hock arthritis or rule it in evaluate the proximal MT3, and here you can see quite readily areas of lysis and sclerosis at the attachment of the PSL, and normal is to the left there. Be careful as you're doing this. Remember, some of your blocks will block other things, in particular the tibial. So you've got to take care, and this is some of these areas that we've been talking about. Here's the lateral malleolus. If that is a chronic OCD, that may sit there happily. If that is traumatic in origin, one of the ways to determine that is there a fusion of the tarsocrural joint? Then that may need to be removed. And then if you look at the picture on the left, then what you're seeing where the arrow is pointing is the lower aspect, which is the medial aspect of the talocalcaneal joint. And there you're seeing quite a little bit of lysis and sclerosis. So any of these will block. Be careful to attribute it to what it is. And you do that with your imaging and not just what you think it is, because all these areas can be blocked with some of these blocks we're using. So how to, which do we do? Do we do medical, surgical treatment of hind limb proximal Spencery and rehabilitation? In our practice, commonly we use medical treatment first, and then we go to surgery if the medical treatment fails. There, again, lots of information out there on hind limb PSLD. The fasciotomy, desmoplasty was the first one. Neurectomy is the more recent one. A variety of numbers. The first one claimed 85%. No one really been able to replicate that since. Newer data is it's down around 60 to 70%. And one of the takeaways here is neurectomy appears to rehab much faster than the fasciotomy does. Again, what are the goals? Relieve compartment syndrome, fascial release, and if you're cutting the nerve here, then you're trying to get neurogenic atrophy of the muscular portion of that proximal ligament that we were looking at earlier, and try to via that shrink the compartment syndrome and the proximal Spencery, stimulate blood flow and heal. Medical treatment, one of the most common is shockwave. And again, not going to go through it in detail. We all know what shockwave does. It stimulates a variety of healing factors that has a significant effect. It also has some effect on small unmyelinated nerve fibers. And we use that. It's short term, but it does help. And then we get increasing cellular proliferation and we accelerate the tissue. The Sharpie's fibers, which of course are the specialized fibers attaching the proximal Spencery to the bone, it stimulates those particularly, and that is one of the tools that we use. So if you have bony involvement, you definitely want to be using shockwave, even if you're using surgery as well. What other medical treatments? Direct infiltration of platelet-rich plasma and stem cells. Sometimes these are done on the surrounding area. We also use alpha-2 macroglobulin more recently. And if it's a lesion directly at the bone, then infiltrate with stem cells or PRP. If it's anti-inflammatory and you're trying to do it more of a swelling aspect, then you're going to try to periligamentously put, say, alpha-2 macroglobulin in the area. If you have MT3 bony lysis, you're going to use Tilgren or Osphos to affect the bony inflammation at the cellular level. And a paper we published showed shockwave, similar success to surgical treatment, and at about 60%. This, we talked about the shoe. This is the Benoit Heinz Suspensory shoe. Again, wide toe, narrow heel quarters. And again, if you wedge the heel, then you are directly transmitting the stress to the, you're taking it off the DDFT and you're putting it on the suspensory apparatus and the superficial digital flexor. So that is contraindicated in most circumstances of proximal suspensory ligament desmitis. Medical rehab is important. Controlled exercise is the key here, and medical treatment, quiet small paddock, sedation is required. Ride or hand walking is still the best exercise we can give them, and complete rehabilitation 30 days after we have completed the shockwave. Shockwave is 3 times 3 weeks apart. And so with surgical treatment, strict stall rest, obviously surgery, and then you follow it a month, 45 days later with beginning of controlled exercise. Again, the point neurectomy tends to require a shorter rehab time due to the less invasive nature of the procedure. Let's put this slide in with my rehabilitation. Mary Bromley rarely got much wrong, and this was one she had right, which is walking for an hour a day is shown to maintain and even improve in some cases the pre-injury fitness level. And so walking these horses, tack walking, is a standard of our rehabilitation aspect. Again, circling back to hock arthritis, it is the most, while we can talk about proximal Spencery, it's the most commonly missed hock area problem. The most common one that is easily recognized is hock arthritis, and it is normally treated with injecting the 2 lower hock joints. Rarely do you inject the tarsocrural joint. That should be done with some trepidation, as you can flare that joint with any variety of the commonly used medications. So try to avoid it unless you prove you need to do it. And this will improve the majority of the horse's gait. Interarticular injections are still the gold standard in hock arthritis. Infections are extremely rare and almost always associated with corticosteroids. Never seen one yet involving an orthobiologic. And again, we would tend to use either alpha-2 macroglobulin would be our pick here, and follow that by PRP. Rarely would we use stem cells in this treatment, but occasionally. Severe hock arthritis is a different beast, and that involves partial collapse of the joint, and it commonly is associated with early developmental orthopedic disease, as we've talked about, that collapsing of that joint. And that's there from a young age, 2 years. Once you've gone through the developmental period, commonly that is what's happened. And you may see partial fusion. Now, unfortunately, it tends to only be partial fusion, and try as you might, it's challenging to get that fused all the way. And a million of the old adages about, well, corticosteroids, nonsteroidals, work them harder, that tends not to be very effective. So this hock OA is going to be, yes, it may be responsive to IA injections, but at a much lower success rate. Again, bony inflammation here is key. So bisphosphonate use is common. And then end-stage treatments include joint fusion with alcohol. Not a big fan of the alcohol fusion. It's hard to get it where you want it to go. And then surgical drilling tends to be, even though the horses are fairly painful for a month or so, it is fairly effective. So again, back to the slide again, don't forget when you've blocked it, there are other things that can be involved. One of the points here, this tallow calcaneal joint, again, this is the medial, the lower aspect. It can be the lateral, which is this upper aspect as well. Here, the lateral's fine. It's all in the medial, which is the more common. And what you'll find is those are very difficult cases to come around. They tend to stay lame and they're challenging. So end here with a slide that I've evolved over the years, but you know, absent a diagnosis, medicine is poison, surgery is trauma, alternative therapy is witchcraft, and rehab is a waste of time. If you don't get the diagnosis right, then none of the other stuff matters. So I tried to stay on time. This is our facility in Virginia on a nice spring day, which is not today. And I believe we're going to do the questions a little bit later in the roundtable. Is that correct?
Yeah, Dr. Allen, thank you very much. Appreciate your presentation this afternoon. We are going to do roundtable for all of the speakers in the last afternoon session collectively. But thank you for that fine presentation.